we will focus hello. Sorry, I don't know what went wrong. I got disconnected.
ما في مشكلة.
Is everything clear now?
It is clear, yeah.
Okay, so in this session, we will focus on the management of stroke, of ischemic stroke, and then we will also talk about different hemorrhagic types of strokes. When we talk about the management of ischemic stroke, there are two elements. First, we will talk about the acute management of ischemic stroke, and then we will talk about the secondary prevention of stroke in patients with TIAs and patients with ischemic stroke. So what is the acute treatment or acute management of ischemic stroke? The first point I would like to mention, the important thing when you are managing, when you are dealing with a patient with stroke, is the presence of acute stroke unit. And this is actually has a prognostic benefit. It was shown according to studies that admission of a patient with ischemic stroke and managing a patient with ischemic stroke in acute stroke unit will reduce the mortality by 30%. This is how important this setting. And unfortunately, these acute stroke units are not widely available worldwide. But if it's available, managing a patient in acute stroke unit will reduce the mortality by 30%. And this can be considered as an initial part of the acute management of ischemic stroke. And also you need to know that, as we all know, ischemic stroke in general is some sort of emergency. So you should deal with a patient, with a stroke patient, as with any patient with emergency. You should always start with ABCs. You should always secure the airways initially. You should make sure that the airways of the patient are patent, because there are certain factors in patients with stroke which can compromise the airways, as we all know. For example, patients with stroke, they might have depressed mental status. They might have reduced level of consciousness. There might be an element of bulbar weakness, swallowing difficulties. There might be vomiting when there is an increase in the intracranial pressure, or if stroke is affecting the posterior circulation. All these factors might compromise the airways. So always pay attention to the airways as the initial part in the acute management of any patient with a stroke, whether it's ischemic or hemorrhagic stroke. So deal with a patient of stroke as an emergency case. And as we said, the patient ideally should be treated and should be managed in acute stroke units if it's available. In acute stroke units, you will have specialized stroke teams. You have a multidisciplinary system with a stroke team. It might include stroke physicians, it might include neurosurgeons, standby. It might include physiotherapists for rehabilitation. There is a stroke team which will be available in acute stroke unit, and this will improve the prognosis to lower the mortality by 30%. Then the next step in the acute management of ischemic stroke, you need to maintain homeostasis. And by maintaining homeostasis, basically, in simple words, I mean that you need to control the factors which will prolong the tolerance of the brain tissue to ischemia. You actually need to prolong the tolerance of brain tissues to ischemia. And when you are dealing with ischemic stroke, the time is the essence. So you need to keep the neurons alive for as much as possible. So you need to control any possible metabolic factor or any other factor which might affect the tolerance of brain tissues to ischemia. For example, if there is an element of hypoxia, you should always correct the hypoxia with supplemental oxygen. But supplemental oxygen should not be given routinely to any patient with a stroke. It should be given only if there is a documented evidence of hypoxia. This is an important rule. Another example of the factors which should be controlled, also the blood glucose in patients with ischemic stroke. A lot of patients with ischemic stroke, they might be diabetics, because diabetes is one of the major risk factors for strokes. So you need to control the blood glucose in the acute settings. You need to keep the blood glucose within normal acceptable range, because both hyperglycemia and hypoglycemia are dangerous to the brain tissue. If you added an element of hyperglycemia or hypoglycemia to stroke, this will shorten the survival of neurons. This will shorten the tolerability of the nervous system, the tolerability of the brain tissue to stroke. So you need to control the blood glucose. And this is an essential part of maintaining the hemostasis in patients with acute stroke. If you have a patient with hyperglycemia, you can consider insulin infusions in order to control the blood glucose. Then another element also here in maintaining the hemostasis, also we need to control the temperature. If the patient is for some reason febrile, you need to give antipyretics, you need to keep the temperature normal, because also high temperatures or even hypothermia might adversely affect the brain tissue. So this is part of maintaining the hemostasis. Then also you need to keep the patient well hydrated. This is an important point, and in a lot of cases, they tend to be neglected. Patients with stroke, in a lot of cases, they tend to be dehydrated. They tend to be hypovolemic. So you need to pay attention to the volume status of the patient. So you need to keep the patient well hydrated, but at the same time, you should pay attention to the airways, because if you are considering hydrating the patient per mouth, you should make sure that the patient is not having any swallowing difficulties. You should make sure that there is no element of bulbar weakness, because hydrating the patient orally when there is bulbar weakness, it can risk complications like aspiration pneumonia. So keep the patient well hydrated. At the same time, keep an eye on the blood pressure. And also you should do a swallow test before considering any per mouth feeding. This is an important, essential part of the treatment. Always do bedside swallow test before giving anything, before giving any form of nutrition or hydration or any form of oral treatment. You should always do swallow test initially. And all these are parts of the hemostasis which should be maintained. Then also another important element here is the blood pressure. Patients with ischemic stroke always tend to present with high blood pressure. Sometimes it tends to be very high blood pressure. And here, this is a gray zone. There are a lot of questions raised in this area, whether to control the blood pressure in the acute settings or to wait or not. But the general trend, hypertension or high blood pressure with acute ischemic stroke should not be controlled, should not be reduced in the first week of acute stroke. So in the first week of acute stroke, you should not lower the blood pressure unless there is an element of hypertension target organ damage. For example, if the patient is having very high blood pressure and there is a target organ damage related to hypertension, like aortic dissection or like myocardial infarction or like acute kidney injury, in these situations, you can start lowering the blood pressure. So as a general rule, high blood pressure in association with acute stroke should not be lowered in the acute setting, should not be lowered, should not be reduced in the first week of the onset of stroke, unless there is an element of hypertension-induced target organ damage. So all these are important parts in the initial acute treatment of stroke. So you need to maintain hemostasis. You need to control the blood oxygen. You need to control the blood glucose. You need to keep the temperature normal. You need also to keep the patient well hydrated. And before that, you need to do a swallow test. And also the blood pressure should not be interrupted, because the high blood pressure seen in the acute settings of stroke is actually part of the cerebral autoregulation. It's part of the autoregulatory mechanisms which tend to maintain the perfusion to the brain. It helps in maintaining the perfusion of the brain to the brain. So it's part of the factors which will prolong the tolerance of the brain tissue to ischemia. And when we talked about how to maintain hemostasis, the first thing I said that we need to prolong. Hemostasis means we need to prolong the tolerability of the brain tissue to ischemia. So interrupting the high blood pressure, lowering the high blood pressure acutely, this actually might compromise the cerebral perfusion further, and it might worsen the condition. So for that reason, this high blood pressure in the acute settings of acute ischemic stroke is actually compensatory. Because actually there is an equation, there is a well-known equation, the cerebral perfusion pressure equals the mean arterial pressure minus the intracranial pressure. So this is an equation. Whenever the mean arterial pressure is increased, the cerebral perfusion pressure should increase, because the cerebral perfusion pressure equals mean arterial pressure minus the intracranial pressure. So lowering the systemic blood pressure, meaning lowering the mean arterial pressure, it can lower the cerebral perfusion pressure. And this is undesirable if you have a patient with acute ischemic stroke. So this is an important point here. Then after that, we should think about obtaining brain imaging. Until this point, initially you are dealing with a patient with stroke. You have a patient with acute stroke. But until this point, you are not sure whether this is ischemic stroke or hemorrhagic stroke. As I said in the previous lecture, the only way to be 100% sure whether this is ischemic or hemorrhagic stroke is by obtaining brain imaging, at least non-contrast brain CT. Unless you do a brain CT, you cannot tell whether this is ischemic or hemorrhagic stroke. So clinically, you cannot differentiate between the two different types of stroke. So brain imaging, usually the initial brain imaging, which should be done in patients with acute ischemic stroke, is non-contrast brain CT, because non-contrast brain CT is widely available and it can be done fast and rapidly. And it's the benefit of non-contrast CT brain is not in confirming the presence of cerebral infarction, because in order for the infarction to appear in the non-contrast brain CT, it might need around 24 or even 48 hours. So in patients presenting early with ischemic stroke, there might not be any evidence of infarction on brain CT. You might have some old infarction, but the new infarction require some time in order to appear in the brain CT. But the main advantage and the main benefit of doing brain CT in the acute setting is in order to differentiate, in order to exclude hemorrhagic stroke. Hemorrhagic stroke can be diagnosed easily on non-contrast brain CT. So we do an urgent or an emergency brain CT to exclude hemorrhagic stroke, not to confirm ischemic stroke. And as a general rule, the brain CT should be done within 24 hours. And if you are considering thrombolytic therapy, as we will talk during this lecture, if you are considering thrombolytic therapy, you should obtain brain CT within 1 hour. So if you are going to do thrombolytic therapy, brain CT should be done within 1 hour. But if thrombolytic therapy is not going to be performed, then ideally brain CT should be done within 24 hours. But initially, you should manage the patient as acute stroke. You should consider acute stroke unit admission. You should maintain hemostasis regardless whether it's ischemic or hemorrhagic stroke. Non-contrast brain CT is the emergency, or it's the initial imaging which should be done. But actually, the most accurate type of imaging which can diagnose ischemic stroke, which can diagnose cerebral infarction, is MRI, specifically diffusion-weighted MRI. If you want to have an accurate diagnosis of cerebral infarction, you need to do diffusion-weighted imaging MRI. This is a special technique or a special protocol of MRI. And this type of MRI can differentiate old from new types of cerebral infarction and can detect cerebral infarction earlier than brain CT. But MRI is not widely available. It's more expensive than CT. It takes time to be performed. And for that reason, it's not recommended to be done as an emergency imaging. As an emergency imaging, we do non-contrast brain CT because it will give us the required information. It will exclude hemorrhagic stroke. But then after that, after stabilizing the patient, then after that, you can consider diffusion-weighted MRI, diffusion-weighted imaging MRI, which is the best type of imaging to confirm cerebral infarction. Also, there is another technique of MRI which can be used, which is perfusion-weighted MRI. Perfusion-weighted MRI, we can use this picture to differentiate between the diffusion-weighted MRI and perfusion-weighted MRI. Focus here on A and B. The diffusion-weighted MRI, basically, what do we mean by diffusion-weighted? In cerebral infarction, whenever there's an infarcted tissue in the brain, what happens is the neurons, when it becomes deprived of blood, when there is cessation of blood flow to one area of the brain, this cessation of blood flow, this interruption of blood flow to the part of the brain will make the neurons in that area hypoxic. Hypoxic neurons will not generate enough ATP. So there is depletion of ATP. And this depletion of ATP will result in dysfunction of the sodium-potassium ATPases within the neurons. And this depletion in the sodium-potassium ATPases will lead to sodium retention inside the neurons. And this sodium retention will be followed by water retention inside the neuron. So eventually you will end up with a type of cerebral edema called cytotoxic edema. Cytotoxic edema is a form of intracellular edema. Here there is an intercellular edema inside the neurons. And when we do diffusion-weighted MRI, diffusion-weighted tests in general, it evaluates and it measures the movement of water molecules in the tissue. It shows how the water is moving and how the water molecules are moving there is restricted mobility of the water molecules in that area. And this can be seen whenever there is an element of cytotoxic edema in the brain tissue. And this cytotoxic edema in the brain tissue can be due to cerebral infarction. So whenever there is an area of cerebral infarction within the brain, this will lead to cytotoxic edema. And this will be detected on diffusion-weighted MRI as an area of restricted diffusion. As you can see here in picture A, this red area or pinkish area, this is the area of restricted diffusion. This is an infarcted brain tissue. And for that reason, diffusion-weighted MRI is the best modality of investigation, the best modality of imaging, which can diagnose cerebral infarction. Then on B here, we have perfusion-weighted MRI. Perfusion-weighted MRI, basically, it's an MRI with a contrast. We use a contrast, and we measure the ability of the tissues to uptake this contrast. The ability of the tissue to uptake this contrast will evaluate the perfusion to this tissue. So in this picture, all these colored area, these are ischemic area. These are area with reduced perfusion. But not all this area is infarcted, because there are specific parts which will be infarcted, and this is the central part here of this area, the red area, similar to here. This is the same patient, and this patient is having MRI at the same time. This is diffusion weighted, and this is perfusion weighted. This central area here is showing an area of infarction, area of restricted diffusion. But here there is a larger area, and this area of reduced perfusion. Reduced perfusion means that this area is ischemic, but not all of this tissue is dead. The infarcted tissues is only found in the central part here, in the core part. This is an infarcted tissue, but the rest of the areas in blue and green colors, these are ischemic, but still not infarcted, still not dead tissue. But so it means it's reversible. So as a general rule, diffusion-weighted MRI will show you the area of infarction. It will appear as restricted diffusion, while perfusion-weighted MRI will show you the area of ischemia, which will be larger than the area of infarction. And this will appear as area of reduced perfusion. So these are basically the two modalities or the two techniques of MRIs which can be used in diagnosing ischemic stroke. But in general, diffusion-weighted MRI is the best one. I hope it's clear so far. Is my voice clear? صوتي واضح؟
ايوه واضح. ما
Okay.
شاء الله جدا.
So after considering brain imaging, the next step is to consider reperfusion therapy. Reperfusion therapy here is an important part of the acute management of ischemic stroke. And reperfusion therapy include two types. We have thrombolytic therapy, which is pharmacological reperfusion therapy, and we have endovascular reperfusion therapy. First, let's talk about the thrombolytic therapy, the pharmacological reperfusion therapy. The basis of reperfusion therapy, the aim of reperfusion therapy is to restore the blood flow to the area of occluded blood vessels. So in ischemic stroke, we know that there is a specific arterial territory which is occluded. And with reperfusion therapy, we want to restore the blood flow to the territory which is ischemic. So we can do that either by thrombolytic therapy or by endovascular therapy. In the thrombolytic therapy, we will use tissue plasminogen activator. Tissue plasminogen activator is a recombinant form of the tissue plasminogen activator. And actually, tissue plasminogen activator is an enzyme. It's one of the endogenous enzymes. It's normally secreted by the endothelial cells. It's produced and released by the endothelial cells. And it's part of the hemostatic mechanisms in our body. Normally, the tissue plasminogen activator, which is released by the endothelial cells, it will activate a plasma protein called plasminogen. And when plasminogen becomes activated, it will be converted into plasmin. Plasmin then acts like a scissor. Plasmin acts like a scissor. It will start to cleave, it will start to degrade the fibrin and fibrinogen. So plasmin will lead to degradation of fibrin and fibrinogen, and this will lead to release of fibrin degradation products like D-dimers, as we know. So this is normal hemostasis in the blood. Whenever there is an activation of the coagulation system, this will be followed by activation of the fibrinolytic system. which acts opposite to the coagulation system. The fibrinolytic system starts with the tissue plasminogen activator, which is an enzyme released from the endothelial cells. And this enzyme will convert plasminogen into plasmin, and then plasmin will cleave the fibrin proteins, and it will cleave the fibrinogen proteins, and this will lead to lysis of the clots in the blood. So in thrombolysis, we will use a drug, we will use a group of drugs which will mimic the action of the endogenous tissue plasminogen activators. And these drugs are called recombinant tissue plasminogen activators. For example, we have a drug called altiplase, we have tenecteplase. And this group of drugs can be used in the acute management of ischemic stroke, and it also can be used in acute coronary syndromes. But there are specific criteria which should be met in order to use these thrombolytic agents. Not any patient with acute ischemic stroke is a candidate for thrombolytic therapy. There are specific criteria which should be required in order to consider reperfusion therapy with tissue plasminogen activator. These criteria, number one, include the patient should present within the window for reperfusion therapy. The window for reperfusion therapy, according to the NICE guidelines, is 4.5 hours. So your patient should present within 4.5 hours from the onset of stroke in order to consider reperfusion therapy. So if the patient is presenting beyond this window, beyond 4.5 hours, then reperfusion therapy will not be considered, because this is an essential criteria which should be met. So if you have a patient with stroke, and with the neurological deficits which appeared since he woke up from sleep, then here you cannot consider reperfusion therapy, because you will not be sure when was the onset of stroke. You need to have an accurate timing of the onset of stroke, and you need to have a window within 4.5 hours in order to consider reperfusion therapy with tissue plasminogen activator. This is the number one criteria for the use of TPA, tissue plasminogen activator. The second criteria, you should do brain imaging. You should do brain CT, non-contrast brain CT, and brain CT should exclude hemorrhagic stroke. Unless you exclude hemorrhagic stroke on brain CT, you cannot do thrombolytic therapy. That's why, as I said previously, brain CT should be done within 1 hour if you are considering thrombolytic therapy. If you are considering thrombolytic therapy, you should do brain CT within 1 hour, and then after you exclude hemorrhagic stroke on brain CT, then you can proceed for reperfusion therapy. But if CT is not obtained, you can never do reperfusion therapy without brain CT. Always brain CT first to exclude hemorrhagic stroke, and then you can consider reperfusion therapy. This is the second important criteria. The third criteria, you should look for the possible contraindications for reperfusion therapy. If there is any contraindication for reperfusion therapy, then it will not be done. So you must make sure that there are no contraindications to thrombolytic therapy. The main absolute contraindications for thrombolytic therapy includes, number one, any history of intracranial bleed. If the patient has any history of intracranial bleed at any time, whatever the type of intracranial bleed, this is an absolute contraindication for thrombolytic therapy in acute ischemic stroke. Then also another contraindication is history of ischemic stroke or history of major head trauma, serious head trauma in the past 3 months. So in the past 3 months, if you have a history of ischemic stroke or history of serious head trauma, this is another contraindication. Then the third contraindication is if you have history of recent major surgery. If there is recent major surgery in the last 14 days specifically, this is a contraindication as well. Then number 4, if you have a history of GIT or genitourinary bleeding in the last 21 days, this is another contraindication. GI or genitourinary bleeding in the last 21 days. Then also if you have an evidence of brain neoplasm. Evidence of brain neoplasm also is a contraindication for thrombolytic therapy, because thrombolytic therapy can lead to hemorrhage inside the tumor, which is very serious. Then another contraindication also if the patient is having any form of coagulopathy. For example, if there is thrombocytopenia, this is a contraindication as well. And also if the patient is on current anticoagulant therapy, if the patient is receiving any form of anticoagulant therapy at the moment when he presented to the stroke, then this is a contraindication as well for thrombolytic therapy. So all these are absolute contraindications for thrombolytic therapy. Also, if you have a blood pressure 185/110, equal or more than 185/110, this is actually also a contraindication for thrombolytic therapy. And at this point, if the only problem for the use of thrombolytic therapy is the high blood pressure, then here you can lower the blood pressure. This is one of the special circumstances in which you can lower the blood pressure acutely in patients with acute ischemic stroke. If the patient is a candidate for thrombolytic therapy, and the only factor which is preventing you from doing the thrombolytic therapy is the high blood pressure, 185/110, here you can lower the blood pressure in order to do thrombolytic therapy as a general rule. So these are the contraindications for thrombolytic therapy. So as a general rule, in order to do thrombolytic therapy, you need to have 3 criteria available. You need, number 1, the patient should be presenting within the window, which is 4.5 hours from the onset of stroke. Number 2, you should obtain brain CT and exclude hemorrhagic stroke. Hemorrhagic stroke should be excluded on brain CT. And number 3, there must be no contraindications to thrombolytic therapy. If all these criteria are met, then you can proceed for reperfusion therapy using tissue plasminogen activators like Altiplase, for example. The main complication which results from tissue plasminogen activators is hemorrhagic transformation of the infarction. This is the main concern. And this is why acute stroke units are important. Because in acute stroke units, you will monitor the patient regularly with a specialized team. And this regular monitoring of the patient can help in detecting early hemorrhagic transformation of infarction following reperfusion therapy. And this is why actually reperfusion therapy should not be performed unless in acute stroke units. This also can be considered as one of the criteria. In order to consider reperfusion therapy with TPA, the patient must be admitted in an acute stroke unit. Otherwise, you should not do reperfusion therapy. This is an important point also related to reperfusion therapy, because the main fear and the main concern with reperfusion therapy is hemorrhagic transformation of the infarction. In reperfusion therapy, actually, whenever there is an ischemic stroke, there are 2 major zones in the territories supplied by the occluded vessel. The core and the central part of the area supplied by the occluded blood vessels will undergo infarction within minutes. It will undergo infarction immediately. And this area will not be saved with reperfusion therapy. And this area is called the core of ischemia, because this area is actually dead tissue. This is an infarcted tissue, which will die immediately once there is an occlusion of a blood vessel. As you can see here, red in color. But the aim of reperfusion therapy actually is not to save this core area, because this area is already lost. We want to save an area around the core. And this area around the core is called the ischemic penumbra. Ischemic penumbra. The ischemic penumbra is a brain tissue around the center of the infarction, which is ischemic, but still reversible. Because ischemia is reversible, as we know, infarction is irreversible, but ischemia is reversible. So when you have a patient with ischemic stroke, you have a central area of infarction, which will be lost, which cannot be saved. But there is an area around the infarction, which is still ischemic, which can be edematous, but still viable tissue, still reversible. And this area, within 4.5 hours, if you interfered within 4.5 hours and you gave reperfusion therapy in an accurate way, you can save this area around the core of infarction. And this is our aim in reperfusion therapy. In reperfusion therapy, we actually want to save the penumbra. So the penumbra is a critical ischemic tissue around the core of infarction in the territory supplied by the occluded vessel in patients with ischemic stroke. And this area is salvageable, it's reversible if reperfusion occurs within the window. This is why we have a window, 4.5 hours, because if reperfusion performed after the window, then there will be no benefit, because even the penumbra at that time would be lost. So you are not saving anything. Actually, you are putting the patient at risk of hemorrhagic transformation. But as long as the patient is presenting within 4.5 hours, here the benefit from reperfusion therapy outweighs the risk of hemorrhagic transformation, because still there is some viable tissue which can be saved. And this actually might improve the quality of life of the patient thereafter significantly. If you save the penumbra, the patient then eventually might be only left with a mild disability. But if you lost the penumbra, then the patient will have more severe disability. So as you can see here, this is the brain tissue of a patient with ischemic stroke. These the territories supplied by the occluded vessel. The red area is the core of dead tissue. Here we have irreversibly injured tissue. This is infarcted tissue. And on diffusion weighted MRI, this area, as I mentioned previously, it will appear here as restricted diffusion area. It indicates that here there is cytotoxic edema. When you have cytotoxic edema, it means that here this area is infarcted. This area is dead. So there is restricted diffusion of water molecules in this part of the brain. But the green area can be detected on perfusion weighted MRI, as you can see here. The area around the red area in blue, green, yellow, these can be considered as the penumbra. These are ischemic areas, but still not dead. That means it's still reversible with the reperfusion therapy. So when you do reperfusion therapy at the right time, we will limit the size of the infarction. We will limit the extent of infarction. So here on the left, this patient in this scenario underwent successful reperfusion therapy. So with successful reperfusion therapy, the core will remain infarcted because the core is already dead tissue, as I said. But the penumbra will be saved. As you can see, there is no green tissue, no green area. Only the red area is lost. So here the patient will have less disability. But if no recanalization, no reperfusion therapy has been done, what you will have is the penumbra will be converted into red area. The green area will be also converted into red area. So you will have a larger extent of the infarct. So you can imagine that this patient will have more disability compared to this patient. So this is the importance of reperfusion therapy, and this is the importance of the window, 4.5 hours, to do reperfusion therapy. As you can see here in A and B, in A, this red area is the area of restricted diffusion, and this indicates that this area is infarcted. Here there is an infarcted tissue. In B, you have a larger area, but this is area of reduced perfusion. Here we're having perfusion-weighted MRI. In perfusion-weighted MRI, you will have an area of reduced perfusion. And that means all this area is having reduced perfusion, is having interrupted blood flow. But actually, the infarcted area is only in the core, in the center, here, as in this picture. The rest of the area with the reduced perfusion is the penumbra. So actually, when you compare these two images, A and B, you can have something called the diffusion. You can have something called the diffusion-perfusion variation, or differences between the diffusion and perfusion. If you interfered and you gave the patient thrombolytic therapy within the right time, then the area of infarction would be only limited to this area. But if reperfusion therapy is not done within the right time, then all this ischemic area, all this area with reduced perfusion on this type of MRI will eventually become red, will eventually become dead. And when you do diffusion-weighted MRI, then after, the red area will appear larger. And it indicates that the penumbra is also underwent infarction. So this is the basis of reperfusion therapy. What you want to do with reperfusion therapy is to save this area, which is called penumbra. And what is keeping this penumbra alive until 4.5 hours, as the window says, is the collaterals. The collaterals, which will supply, in a lot of patients, there are a lot of collaterals, and these collaterals will be successful in supplying the penumbra, but it will not help the core of ischemic tissue. And these collaterals have a capacity. And if you exceeded the capacity of these collaterals, eventually, even these collaterals will fail to supply the penumbra, and eventually the penumbra will become infarcted as well. So the main point of reperfusion therapy is to limit the size of infarction. Then, as we said, also there is another type of reperfusion therapy beside thrombolysis, and this other type is endovascular reperfusion therapy. Endovascular reperfusion therapy can be done with endovascular intra-arterial thrombolysis, and in this type of endovascular procedure, the neuroradiologist will actually inject thrombolytic agents directly into the occluded vessel. This is called intra-arterial thrombolysis. Another form of endovascular intervention which can be done in reperfusion therapy is endovascular mechanical thrombectomy. And this is another also endovascular intervention, which can also restore the patency of the blood vessel. It can be similar to what's done in the peripheral vascular disease. When you have an acute limb ischemia, then you can do an embolectomy. This is similar. You have endovascular mechanical thrombectomy. So the endovascular reperfusion can be either endovascular intra-arterial thrombolysis or endovascular mechanical thrombectomy. In general, the endovascular reperfusion can be considered only if you have ischemic stroke due to occlusion of the proximal parts of the cerebral circulation. And if there is occlusion of the proximal part of the anterior circulation or occlusion of the proximal part of the posterior circulation. For example, if you have occlusion of the internal carotid artery or occlusion of the proximal part of the middle cerebral artery or occlusion of the vertebral artery in the posterior circulation. Under these circumstances, then endovascular reperfusion can be done. But if the occlusion is distal, then you cannot do endovascular reperfusion. So reperfusion therapy can be either pharmacological reperfusion using thrombolytic therapy with tissue plasminogen activator, or it can be endovascular reperfusion either with endovascular intra-arterial thrombolysis or endovascular mechanical thrombectomy. Then after reperfusion therapy, another important also part of the acute treatment of ischemic stroke is antiplatelet therapy. Antiplatelet therapy in general should be started immediately after excluding hemorrhagic stroke on brain CT if the patient is not a candidate for reperfusion therapy. And if you do not do reperfusion therapy and there is no hemorrhage on brain CT, then you should start antiplatelet therapy immediately. But if the patient underwent reperfusion therapy, then antiplatelet therapy should be started after 24 hours from reperfusion therapy. And in the acute treatment of ischemic stroke, actually, according to studies, there are two large trials. We have the international stroke trial, and also we have the Chinese acute stroke trial. These are two large trials which have demonstrated that aspirin monotherapy in the acute treatment of stroke is associated with significant reduction in the recurrence of stroke, especially within the early 2 weeks after the onset of stroke. And also it's associated with reduction in mortality from stroke. And for that reason, in the acute treatment of stroke, we always use aspirin monotherapy. We use high dose of aspirin, 300 milligram, and we give it for 2 weeks. This is the acute treatment of ischemic stroke, because it was shown according to studies, aspirin, if it's initiated in the acute treatment of stroke alone, it will reduce the risk of recurrence of stroke, especially within 2 weeks, and it will also reduce the mortality from stroke. For that reason, we use aspirin 300 milligram for 2 weeks. And then after 2 weeks, we will continue with clopidogrel according to the NICE guidelines. We will switch from aspirin to clopidogrel 75 milligram, and clopidogrel will be used as a long-term treatment for secondary prevention. So when you use clopidogrel after 2 weeks, actually, we use it for secondary prevention. This is not part of the acute treatment. The acute treatment with antiplatelet therapy is with aspirin high dose for 2 weeks. And this aspirin therapy should be considered in any patients, for any patient without hemorrhagic stroke on brain CT. And if the patient is not a candidate for reperfusion therapy, it should be started immediately. If the patient underwent reperfusion therapy, then antiplatelet should be given after 24 hours from reperfusion therapy. So an important point here, we use aspirin monotherapy, aspirin alone, not combination of aspirin and clopidogrel in the acute settings. Aspirin is used alone for 2 weeks, and then it will be followed by clopidogrel for secondary prevention after 2 weeks. Then another also element in the acute treatment of ischemic stroke is anticoagulation. Anticoagulation actually is not used in all cases of acute ischemic stroke. The evidence and the benefit from anticoagulation is seen in patients with cardioembolic stroke. When we talked about the mechanisms of stroke in previous lecture, we talked about cardioembolic stroke as a possible mechanism, and also we talked about other mechanisms like atherosclerosis. So stroke in general can be either cardioembolic or it can be non-cardioembolic stroke. And anticoagulation can be beneficial in cardioembolic stroke. If you have cardioembolic stroke, then there is evidence that anticoagulation can be beneficial. But actually, anticoagulation can be associated with increased risk of hemorrhagic transformation of the cerebral infarction if it's initiated in the acute settings. And for that reason, according to the NICE guidelines, it's recommended that to wait at least 2 weeks, wait 2 weeks after the onset of ischemic stroke until you start anticoagulation therapy if indicated. So if you have a patient with cardioembolic stroke, this is an indication for anticoagulation therapy. But you should not start the anticoagulation therapy immediately according to the NICE guidelines. You should wait 2 weeks from the onset of ischemic stroke because early use of anticoagulation following cerebral infarction carries a risk of hemorrhagic transformation of the stroke. There are other schools and other guidelines which recommend earlier initiation of anticoagulation, but as far as for the NICE guidelines, it's recommended to wait 2 weeks. So the main indication of anticoagulation therapy in acute management of ischemic stroke is in cardioembolic stroke. But in non-cardioembolic stroke, actually, anticoagulation was shown to be inferior to aspirin. If you have a non-cardioembolic stroke, using aspirin instead of anticoagulation is better than using anticoagulation. And actually, anticoagulation in non-cardioembolic stroke is associated even with higher risk of hemorrhagic transformation. So it's totally unnecessary and it's even harmful. So anticoagulation is only used when there is a cardioembolic stroke, especially in case of atrial fibrillation. Another situation or another indication in which anticoagulation might be considered is if there is venous thromboembolism, which is one of the possible mechanisms, one of the possible complications associated with stroke. As we all know, patients with stroke are prone to develop DVT, which can be complicated with pulmonary embolism. And this is an indication for anticoagulation. And so this is another indication beside cardioembolic stroke. Then also we have statins, lipid-lowering therapy. Statins actually is recommended to be given in patients with ischemic stroke, even if the patient is having normal lipid profile, because actually the benefits of statin is not just related to its lipid-lowering effect. Statins are not just lipid-lowering agents. It was found that this group of drugs, statins, also are having antioxidant and anti-inflammatory effects on the atherosclerosis. As we know, atherosclerosis, which is behind most of the types of strokes, it's a major mechanism leading to stroke. Atherosclerosis is considered as a chronic inflammation in the vessels. And the more the inflammation in the vessels, you have more risk of atherosclerotic complications like stroke. So your aim is to keep the atherosclerotic plaque on the blood vessels, is to keep this plaque stable. You want to keep this plaque stable as much as possible. How to keep this plaque stable? By lowering the inflammation inside the plaque, because more inflammation inside the plaque, this will lead to more risk of plaque rupture and plaque complication, which will lead to stroke, which will lead to acute coronary syndrome. In order to reduce the inflammation in the plaque, you need to control the risk factors of atherosclerosis. You need to control diabetes, hypertension, smoking, dyslipidemia with the statin. But along with that, statin, in addition to lowering the blood lipids, it will also control the inflammation in the plaque. It has a direct anti-inflammatory effect on the atherosclerotic plaque. So it will make the plaque more stable. And hence, it will reduce the risk of complications related to the rupture of the plaques. It will reduce the risk of acute coronary syndromes. It will reduce the risk of peripheral vascular disease and cerebrovascular disease as well. And for that reason, statins are recommended as part of the management of ischemic stroke. It's initiated in the acute settings. And according to special guidelines, they mentioned that statins should be used 48 hours after the onset of stroke. So statins, it's not recommended to be used immediately on day one. It's recommended to be used 48 hours after the onset, because in the first 48 hours, it was shown that there's a slight increase in the risk of hemorrhagic transformation with the statin. So it's better to wait 48 hours from the onset of stroke, and then you can initiate statin therapy. And it's part of the long-term treatment, long-term therapies for secondary prevention of ischemic stroke, as we will talk next during this lecture. So all these are important elements in the acute management of ischemic stroke. Then also there is an element of surgery as well. There is surgical intervention, which can be considered in the acute management of stroke. And this surgery is usually considered if ischemic stroke is associated with large volume of infarction, and which has led to increase in the intracranial pressure. Sometimes, especially when there is middle cerebral artery territory stroke, you can have something called malignant MCA syndrome, in which there is large area of infarction. along the middle cerebral artery territory. And this is similar to what we discussed in previous lecture. When there is proximal occlusion of the middle cerebral artery, it will lead to, if there is proximal occlusion of the middle cerebral artery with poor collateralization, this can lead to large area of infarction, and this is called malignant MCA syndrome. And this large area of infarction will be associated with large area of cerebral edema, and this cerebral edema will increase the intracranial pressure significantly, and so this can risk brain herniation. In these situations, here there is a rule for surgical intervention with hemicraniectomy, decompressive hemicraniectomy. The surgeon will simply remove part of the skull, and this will help to alleviate and will help to reduce the intracranial pressure. And actually, this procedure and this type of surgery in selected patients has been shown to reduce the mortality in patients with a stroke. So if you have a patient with large volume infarction associated with increased intracranial pressure, doing decompressive hemicraniectomy will actually reduce the mortality. This is an important also part in the acute treatment of ischemic stroke. So there is a rule for surgery. Then after that, also surgery in form of endovascular endarterectomy to remove the atherosclerotic plaque in the extracranial vessels is considered for secondary prevention. Not in the acute treatment, it's for secondary prevention if you have more than 70% occlusion, 70% or more occlusion in one of the extracranial carotid vessels. We will talk about that also in the secondary prevention. And after that, of course, in the acute, in acute management of ischemic stroke, the next, after all these elements in the treatment, then you should also consider rehabilitation. You should consider supportive management. You should take care of the bowel. You should take care of the bladder. You should take care of the skin and prevent bed sore. You should take care of breathing to prevent and to treat also aspiration pneumonia if it's developed. You should take care of nutrition of the patient. As we said, initially, you should always do a swallow test to make sure that there is no element of bulbar weakness. And physiotherapy also is an important part of rehabilitation. And actually, physiotherapy, and it has two main benefits. As we know all, physiotherapy is important to prevent contractures. It's important for early mobilization to prevent contractures of the limbs. But also, it was shown that physiotherapy will improve also something called neuronal plasticity. There are a lot of patients with stroke. Initially, they might present with a significant disability. There might be hemiplegia, dense hemiplegia. There might be aphasia. There might be a lot of disabilities. But after a while, after a few months from physiotherapy, the patient might start to regain some functions, and the disability might become less with time. This reduction in the disability was found to be related mainly to a phenomenon called neuronal plasticity. The neuronal plasticity actually means that the adjacent neurons which are adjacent to the area of infarction, as the time goes by, these neurons adjacent to the area of infarction will start to acquire the functions, some of the functions which was carried by the infarcted tissue. Yeah, for example, if the dead tissue is in the motor area, then the neurons around the motor area for the upper limb, for example, might start to exert some motor function. And there might be some improvement in the weakness. And this might lead to improvement in the disability after stroke. And it was shown that this neuronal plasticity is actually improved and encouraged by physiotherapy. So physiotherapy is not something to be taken for granted. It's an important part of rehabilitation. It should be considered for any patient with stroke, following stroke, because it tends to enhance the neuronal plasticity after stroke. And this helps to improve the long-term disability. And it will improve the quality of life. Here we have scale, which is called National Institutes of Health Stroke Scale. This scale or scoring system can be used for evaluating the severity of stroke. Actually, it's not used ideally to diagnose a stroke or to differentiate ischemic from hemorrhagic stroke. This scale is used to evaluate the severity of stroke. And here we use 11 parameters. As you can see, there are 11 parameters which can be used. You can go back to the website of the National Institute of Health Stroke Scale, and you can find the scale more clearly. And according to this scale, we have a scoring system, and the total score is 42. So you have a score from 0 to 42. And according to your total score, the severity of stroke can be classified into minor stroke, if your score is between 1 to 4, moderate stroke, 5 to 15, moderate to severe, and finally severe stroke. And this can help in evaluating the severity of stroke. So after talking about the acute treatment of ischemic stroke, then let's talk about the secondary prevention of stroke in patients with TIA and stroke. If you have a patient with an episode or multiple episodes of TIAs, or patient with a history of stroke, after the acute treatment of stroke, the next step, you want to prevent the recurrence of stroke. Or in case of TIA, you want to prevent the first episode of stroke after TIA. So this is called secondary prevention. This is not primary prevention. Primary prevention basically means preventing TIA and stroke from the beginning, preventing the first attack of TIA or stroke. And in primary prevention, the main point is to control the risk factors associated with the stroke, which are the risk factors of atherosclerosis. But in the secondary prevention, there are multiple elements. The first part of the secondary prevention is control of the risk factors. Control of the risk factors means that the risk factor for atherosclerotic disease. What accelerates atherosclerotic disease? You should control anything which can accelerate atherosclerotic disease. Controlling the risk factors starts with exercise and diet. This is very important. Exercise and diet actually have an important impact in the secondary prevention of stroke. Regular exercise has been shown to reduce the risk of recurrent strokes. And also, when you talk about the diet, according to the American Stroke Society and American Heart Association, they found that the low-salt Mediterranean diet is associated with reduction in the recurrence of stroke, and associated also with significant reduction in the recurrence of stroke. And it was considered superior to low-fat diet. In the past, and conventionally, we used to consider low-fat diet as the main type of healthy diet to prevent atherosclerotic complications. But the Americans, the American Society, the American Stroke Association, and the American Heart Association, they found that the low-salt Mediterranean diet is superior to the low-fat diet. The low-salt Mediterranean diet, it includes some types of vegetables and fruits, it includes nuts, it includes also certain types of seafood. You can Google it and you can find specifically what are the specific elements in this Mediterranean diet, but it was found according to studies to be beneficial and to be associated with reduction in the recurrence of stroke. And this is part of controlling the risk factors. Then after that, as we know that the major risk factors in atherosclerosis include hypertension, diabetes, smoking, and dyslipidemia. When you talk about hypertension, according to the American Stroke Association, the target blood pressure in order to prevent the development of stroke as part of the secondary prevention is 130/80. You need to keep the blood pressure less than 130/80. This is the target blood pressure. And the antihypertensive drugs, which have been shown to reduce the risk of recurrence of stroke according to guidelines, include thiazide diuretics and ACE inhibitors and ARBs. So ACE inhibitors and angiotensin receptor blockers and thiazide diuretics. These are the three groups of antihypertensive drugs which have been shown according to studies to reduce the risk of recurrence of stroke. So if you have a patient with a history of TIA or a history of stroke, for secondary prevention, you should consider controlling the blood pressure with these three groups of antihypertensive drugs. And surprisingly, calcium channel blockers and beta blockers as well, they have not been shown to reduce the risk of recurrence in stroke. A lot of people might think that calcium channel blockers or beta blockers are associated with reduction in stroke recurrence, but actually calcium channel blockers and beta blockers have failed to show any reduction in the risk in the recurrence of stroke according to studies. So the three groups of drugs are thiazide diuretics, ACE inhibitors, and ARBs. These are the drugs which have been shown to reduce the risk of recurrence of stroke as part of the secondary prevention. Then when we talk about diabetes, in diabetes also, which is a major risk factor, which should be controlled, we should use an anti-hyperglycemic drugs which have been to be associated with reduction in the cardiovascular complications. There are certain anti-hyperglycemic drugs with evidence of reduction in the cardiovascular complications. This includes groups like GLP-1 agonists, glucagon-like peptide-1 agonists, And it includes also the SGLT2 inhibitors, the sodium glucose co-transporter inhibitors. The GLP-1 agonist and the SGLT2 inhibitors, these are two important groups of anti-hyperglycemic drugs which have been shown to reduce the risk of recurrence of stroke. And if there are no other contraindications, we should always consider these two groups of drugs in controlling diabetes as part of the secondary prevention of stroke. So this is an important point. When you are dealing with hypertension, for secondary prevention of stroke, we should use antihypertensive drugs with prognostic benefits, antihypertensive drugs which have been shown to reduce the recurrence of stroke, according to studies. And when you're talking about diabetes, you should use also vascular active agents, yani drugs with cardiovascular benefits, like GLP-1 agonists and like SGLT2 inhibitors, like empagliflozin, for example, or dapagliflozin. Then also you should consider smoking cessation. And this is very important. As I mentioned previously, quitting smoking after 1 year will reduce the risk of atherosclerotic complication by 50%. This is how huge the impact of smoking on cerebrovascular disease and on cardiovascular disease. And also alcohol cessation is important. All these are part of the control of risk factors. And this is part of the secondary prevention of stroke in patients with TIA or in patients with stroke. Then the next step is to consider antiplatelet therapy. Antiplatelet therapy is an essential part of the secondary prevention of stroke. And as I said previously, antiplatelets actually initiated in the acute treatment, in the acute setting of stroke and TIA. And then after that, it will be used for secondary prevention. In stroke, as I said previously, we start with aspirin monotherapy for 2 weeks. And it has been shown to reduce the risk of recurrence and to reduce the mortality. And then after that, we will continue with clopidogrel monotherapy as secondary prevention. So for antiplatelet therapy, initially we give aspirin according to the NICE guidelines. We give aspirin 300 milligrams for 2 weeks, and then it will be followed by clopidogrel monotherapy. Then there's special type of trials which have been made, and it was shown that in selected type of patients, you can use dual antiplatelet treatment in the acute settings. And specifically, we can use aspirin and clopidogrel in combination for 21 days. And after that, we will continue with a single agent, with a single antiplatelet, which is clopidogrel. So in certain patients, instead of using aspirin initially and then followed by clopidogrel, we can use aspirin and clopidogrel combination initially. And according to the studies, this group of patients, which can be a candidate for this strategy, include patients with TIA with ABCD score of 4 or more. We know that there is a scoring system in TIA called ABCD2 score. If you have an ABCD score in patient with TIA score of 4 or more, or if you have a patient with a stroke, with ischemic stroke, with minor stroke, according to the NIH stroke scale, 1 to 4, and you have patient with minor stroke 1 to 4, or patient with TIA with ABCD score 4 or more. In these patients, you can consider initially dual antiplatelet therapy, aspirin in combination with clopidogrel for 21 days only. After that, to be followed by clopidogrel alone. And this has been shown to significantly reduce the risk of recurrence of stroke. This is an important point when you talk about the antiplatelet therapy. But as a general rule, dual antiplatelet therapy should not be used for long-term therapy. Always, when you are considered dual antiplatelet therapy in the management and prevention of stroke, it should be used, if it's used, it should be used for a short duration, 21 days. It should not be used as for long-term treatment, for secondary prevention, because it has been shown that it will increase the risk of intracranial hemorrhage, especially in elderly patients. So for long-term treatment, we always use one antiplatelet drug. But in the acute settings, we can either use aspirin, 300 milligrams for 2 weeks, or we can consider combination of aspirin and clopidogrel for 21 days if the patient with TIA is having 4 or more score, ABCD score, or the patient is having minor stroke according to the NIH stroke scale. So that's all about antiplatelet therapy as part of the secondary prevention of stroke. Then anticoagulation as well can be considered as part of the secondary prevention if you have patient with atrial fibrillation specifically, or patient with cardioembolic stroke. Then in these circumstances, anticoagulation should be considered as part of the secondary prevention. And it was shown that the direct-acting oral anticoagulants like rivaroxaban and like apixaban are superior to warfarin when you are dealing with mechanical valves or mitral, when you are dealing with any form of cardioembolic stroke, except mechanical valve and except mitral stenosis. So if you have an atrial fibrillation or any form of cardioembolic stroke, which is unrelated to mechanical valves and unrelated to mitral stenosis, in these patients, the direct-acting oral anticoagulants are superior to warfarin. So the only circumstances in which warfarin is superior to the direct-acting oral anticoagulants in secondary prevention of stroke is in mitral stenosis and in mechanical prosthetic valves. This is a general rule according to the guidelines. So direct-acting oral anticoagulants are superior to warfarin in secondary prevention of stroke, except in mechanical valves and in mitral stenosis. Finally, also, as part of the secondary prevention, there is some sort of endovascular intervention, surgical intervention, which is carotid endarterectomy. Carotid endarterectomy is done whenever you are having carotid stenosis, extracranial carotid vessels, stenosis of 70% or more. In these patients, it was found that carotid endarterectomy improved the outcome significantly. So the main indication for carotid endarterectomy in secondary prevention of stroke is if you have an extracranial carotid stenosis of 70% or more. If the patient is a candidate for carotid endarterectomy, and there is 70% or more occlusion, stenosis, but the patient is unfit for carotid endarterectomy because carotid endarterectomy is an invasive surgery in which a surgeon will remove the atherosclerotic plaque simply. If the patient is unfit for this type of surgery, the alternative will be carotid angioplasty with stenting. What we will do is similar to PCI. We will dilate the stenotic area and we will insert stent. So carotid angioplasty and stenting is inferior to carotid endarterectomy, but it's considered if the patient is a candidate for carotid endarterectomy but unfit for surgery. So these are the elements of the secondary prevention of stroke. Whenever you are dealing with a patient with a history of TIA or a patient with a history of ischemic stroke. I hope it's clear so far.
It's clear, Dr. Khalid. I just have a question regarding the statin, if you don't mind, please.
Regarding what? Sorry?
The statin. So statin should be stopped for 2 days after the attack, even if the patient was taking the statin before the attack, or just if I need to start it for the patient.
Actually, regarding statins, here في gray area. في different schools. There are some areas which advise actually starting statins from the start, and there are areas which advise start after 48 hours. But if the patient was already on statin, you can continue on a statin. You do not need to stop it. The idea is about initiation of statin. If the patient was statin naive, patient was not on statin.
So I don't need to stop it if the patient.
No, you don't need to stop it. There is no strict guidelines which advise stopping it if the patient is already on statin. And statin actually also another part of the secondary prevention, as I said, is part of controlling the risk factors. Statin therapy should be considered also to control dyslipidemia, which is a major risk factor for atherosclerosis. And according also to the ASA, it's recommended to start to use high dose of atorvastatin, use atorvastatin 80 milligram for secondary prevention of stroke. And the target LDL is less than 70. You need to keep the LDL level less than 70. This is a target. And if this target is not achieved with atorvastatin alone, then you can add ezetimibe as well, which is another lipid lowering agent, according to the guidelines. So it's advised to add ezetimibe if statin alone failed to reach the target LDL, which is less than 70.
Thank you.
So that's all about. Hello?
Is it the time for questions, or when we are all?
Yes. Go ahead.
Because I have a list of questions. I don't know. Should I go through all of them together?
Yes, you can go. No problem.
Okay, so regarding the blood pressure target, you thought that it should be if the patient is a candidate for thrombolysis and the blood pressure is more than 185/110, then yes, at that point we can decrease the blood pressure before going to thrombolysis. So if the patient is not like a candidate for thrombolysis, and his blood pressure is more than 185 over 110, still we can like try to bring the blood pressure down. I mean, any target for ischemic stroke, blood pressure for ischemic stroke, if the patient is not going for thrombolysis?
No, actually the guidelines were strict here. They advised only to lower the blood pressure if you have an evidence of hypertension target organ damage, like aortic dissection, like myocardial infarction, like heart failure, if it's known to be related to hypertension at that time. This is the only way where it's advised, and it's to lower the blood pressure acutely. Or if the blood pressure is 185 over 110 and the patient is a candidate for reperfusion therapy. Otherwise, blood pressure should not be lowered. If the patient is not a candidate for reperfusion therapy and there is no evidence of target organ damage, then you should not lower the blood pressure in the acute setting of stroke, because this will compromise the cerebral autoregulation and it will increase the extent of infarction, because this high blood pressure actually is what's keeping the penumbra alive. The penumbra is kept for a certain time alive because of this cerebral autoregulation, because the collaterals which supply the penumbra is driven by the systemic blood pressure, it's driven by the mean arterial pressure. The increase in the blood pressure is what keeping the collaterals alive and supplying the penumbra. When you compromise this autoregulation, you will risk increasing the extent of the infarct.
And if it is a hemorrhagic one, then we can go through reduction of blood pressure.
In hemorrhagic, we will talk about it. We will speak about hemorrhagic stroke in this lecture, and we will talk about how to control the blood pressure. But as far as for ischemic stroke, just like I told you.
Okay, so if it's you went through the contraindication for thrombolysis, if the size of the infarction is still one of the things to be considered before thrombolysis?
Actually, this also in certain guidelines, they are talking about the size of the infarction, but it's not strict. When we talk about NICE guidelines specifically that we are following here, mainly, the size of the infarction is not a big issue. We are considering thrombolysis according to the window, according to the contraindications, if there are any contraindications or not, according to the availability of stroke units, acute stroke unit. This is an important point, but the size of infarction will not affect our decision whether to start or not to start reperfusion therapy. So it means that for any patient who I consider stroke, I will go directly for plain head CT, and no need for me to do DWI to determine the size. So if the plain CT, there is no hemorrhage, so I can go directly for the thrombolysis. There is no contraindication and no need for me to do DWI. Yes, exactly. The decision of thrombolysis is based on non-contrast brain CT, and because it's done actually fast. If you waited for DWI, MRI, you might lose the time. You have a very narrow window, 4.5 hours, and you never know when the patient will present to the hospital. The patient might present after 3 hours. So you cannot just wait until you do DWI. You will just base your decision on the brain CT. Okay, so the other question, sorry. Yes, there is any criteria where we need to choose between systemic thrombolysis and endovascular thrombolysis? If you have a patient within the window and you have the facilities available for endovascular thrombolysis and the occlusion is in the proximal part of the anterior or posterior circulation, endovascular is always superior to pharmacological thrombolysis. Okay. You got my point? So you need the facility. The main point, you need the facilities available. It's not available in every center. Even in developed countries, you're not always having the possibility to do endovascular intervention. Okay, regarding the long term, sorry, these questions are very, very helpful. Yeah, okay. Okay, regarding the long term for the clopidogrel, it will be life definite treatment. I need to continue with it. And the other question, okay, so it's lifelong then. And regarding statins, any targets for the control of the lipid profile, like in ACS? The same for stroke, or there is different targets? You mean in ACS? I mean any target, because there is targets for lipid control in ACS patients. Is it the same? Yeah. There is targets also in stroke patients. The only people who actually spoke about the target the target lipid, LDL specifically, are the American Association of Stroke and American Heart Association. They address this point more than the NICE guidelines. They advise that the target LDL-C should be less than 70. And you should achieve this target even if it's not controlled on atorvastatin alone. They recommend to start with atorvastatin, high dose 80 milligram. And if this target is not achieved during the follow-up, you should add another lipid-lowering agent, and they prefer ezetimibe as the next drug to be added. And clopidogrel, of course, should be, for secondary prevention, you need a lifelong antiplatelet monotherapy, not dual therapy. And this is important, unless there is some contraindication. It's sometimes, if clopidogrel is not tolerated or contraindicated for some reason, the alternative, according to the NICE guidelines, they consider the combination of aspirin and slow-release dipyridamole. This is the only situation where dual antiplatelets are used for long-term treatment. But aspirin with dipyridamole is not a serious problem compared to aspirin and clopidogrel. The main problem is continuing aspirin and clopidogrel as long-term and lifelong treatment for secondary prevention of stroke. This has been shown to increase the risk of intracranial hemorrhage, especially when you are dealing with elderly patients. This is different than acute coronary syndrome. In acute coronary syndrome, we always tend to use dual antiplatelet therapy, especially after stenting. But when you are talking about TIAs and strokes for secondary prevention, we always use immunotherapy antiplatelet.
And this monotherapy couldn't be aspirin instead of clopidogrel?
Aspirin, according to studies, was shown to be effective in the acute settings, but on the long run, the risk of hemorrhage with aspirin is more than the risk of hemorrhage with clopidogrel. That's why clopidogrel is preferred over aspirin as part of the long term for secondary prevention. And this is according to the NICE guidelines.
Okay.
But if you are considering aspirin, aspirin is considered if the patient is not tolerating clopidogrel, then you can consider aspirin. And they even recommend to combine aspirin in a small dose with slow-release dipyridamole, as I said.
Okay, so last question. Regarding the anticoagulation for a patient with cardioembolic stroke. You mean that I can start the anticoagulation after 2 weeks from the acute stroke? So yes. The patient is still risky for another embolic phenomenon because he had atrial fibrillation. So aspirin is not going to be enough. Am I right?
Yes, you are totally right. And according to the SHATS score, nowadays aspirin is not considered actually as part of the secondary prevention to prevent stroke in patients with atrial fibrillation. It was pre-old guidelines. We always consider anticoagulants nowadays. But in the acute settings of stroke, there is a risk of hemorrhagic and high risk of hemorrhagic transformation of the infarction with anticoagulation. So, this is a tough equation, whether to give the patient anticoagulation and to risk hemorrhagic transformation, or whether to keep the patient off anticoagulation in the acute setting and to risk another cardioembolic phenomenon. That in the next time, it might go, for example, to the lower limb, causing limb gangrene, it might go to the bowel, causing bowel infarction, and so on. But NICE guidelines, they advise to start anticoagulation after 2 weeks. But there are other schools which can consider the anticoagulation therapy prior to 2 weeks, and can be considered anticoagulation therapy in the acute settings according to the size of the infarction. This is the area where the size of the infarction might affect your treatment options. In certain guidelines, they advise that you can initiate anticoagulation earlier in the acute settings if you are sure that the size of the infarction is not severe. There is mild area of infarction. I'm not sure exactly what are the details of these guidelines, but I might send you a link later on. But in general, according to the NICE guidelines, if we are talking about MRCP, in this area exactly, they're always recommending to wait 2 weeks in both stroke and TIA. Wait 2 weeks until you start anticoagulation in patients with atrial fibrillation.
Okay, thank you so much.
You're welcome. Any other questions? So, okay. After we talked about ischemic stroke, now let's talk about hemorrhagic strokes. As we said previously, hemorrhagic strokes are less common than ischemic strokes. We have two types of hemorrhagic strokes. We have intracerebral hemorrhage and we have subarachnoid hemorrhage. First, we'll talk about intracerebral hemorrhage, which is representing majority of cases of hemorrhagic stroke. Intracerebral hemorrhage basically means bleeding into the brain substance, bleeding into the brain parenchyma. And ideally speaking, it should be called brain intraparenchymal hemorrhage rather than intracerebral hemorrhage, because this type of hemorrhagic stroke not always will appear on the cerebral hemisphere. So it's not always intracerebral. Sometimes it might be cerebellar. It might be pontine within the brainstem. So it's not always intracerebral. So ideally, it's brain parenchymal hemorrhage, regardless the site of the brain parenchyma where there is hemorrhage. But as a general rule, we call it intracerebral hemorrhage. So what are the possible causes of intracerebral hemorrhage? When you talk about intracerebral hemorrhage, always think about hypertension. It's always related to hypertension. This is the most common cause of intracerebral hemorrhage. That's why we call it hypertensive intracerebral hemorrhage. And in non-hypertensive patients, if you have a patient who's not hypertensive presenting with intracerebral hemorrhage, in these situations, you should think of something called cerebral amyloid angiopathy. Cerebral amyloid angiopathy is a condition in which there is deposits of abnormal beta amyloid proteins within the wall of the cerebral blood vessels. So there is selective deposition of abnormal beta amyloid proteins within the walls of cerebral blood vessels. And this leads to some sort of vasculopathy. It leads to occlusive vasculopathy. And this can lead to recurrent episodes of TIAs in some patients. And sometimes also this deposition of amyloid proteins within the cerebral blood vessels will also risk rupture of these blood vessels, and it can lead to intracerebral hemorrhage. So if you are dealing with non-hypertensive patient with intracerebral hemorrhage, think of cerebral amyloid angiopathy. This is different than systemic amyloidosis. In cerebral amyloid angiopathy, there are no deposits of amyloid proteins in other parts of the body. You will not have nephrotic syndrome, membranous glomerulonephritis. You will not have restrictive cardiomyopathy and other features of systemic amyloidosis. It occurs in isolation, only within the cerebral blood vessels. This is similar to what's seen in patients with Alzheimer's disease. In Alzheimer's disease, when you do brain biopsy, you will find deposits of amyloid proteins within the cerebral cortex. And also in diabetes, in type 2 diabetes. In type 2 diabetes, when you do also pancreatic biopsy, when you examine the islet cells of the pancreas, also you will have amyloid beta deposition, and this is contributing in the progression of type 2 diabetes. So this is similar to what happens there. This is an isolated deposits of amyloid proteins within the cerebral blood vessels, which can lead to intracerebral hemorrhage. Then we have other uncommon causes like arteriovenous malformations, and arteriovenous malformations can lead to both intracerebral hemorrhage and subarachnoid hemorrhage. And you should consider it, especially if you have a young patient presenting with hemorrhagic stroke. Then you have venous sinus thrombosis, intracranial venous thrombosis. In the intracranial venous thrombosis, what you will get is hemorrhagic infarctions. It's usually associated with hemorrhagic infarctions. We know that stroke can be arterial, ischemic stroke can be arterial, or less commonly venous. In venous stroke, the infarctions will be associated with hemorrhage. It's called hemorrhagic infarctions. And this hemorrhage associated with infarction, it can be considered as an intracerebral hemorrhage. And then also, as we know, coagulopathies, different types of coagulopathies, whether it's inherited or acquired coagulopathy, can lead to intracerebral hemorrhage. And this even includes hemorrhagic transformation of the infarction. When you have hemorrhagic transformation of infarction following thrombolysis or anticoagulation, this is considered as a form of intracerebral hemorrhage. And finally, we have hemorrhage into the brain tumor. And this is why actually thrombolytic therapy, if you have a brain neoplasm, it's a contraindication for thrombolytic therapy because it can lead to hemorrhage into the brain tumor. And this can increase the intracranial pressure significantly. So all these are possible causes of intracerebral hemorrhage, which is bleeding into the brain parenchyma. And the most important cause is hypertension. The next point we would like to know about intracerebral hemorrhage is what are the sites of this type of bleeding? The sites of intracerebral hemorrhage can be in the cerebral hemisphere, in the cerebrum, or it can be below the cerebrum. It can be in the brainstem, or it can be in the cerebellum. The most common site of intracerebral hemorrhage is in the basal ganglia, which is part of the subcortical structures of the cerebral hemisphere, and specifically in the putamen part of the basal ganglia. So you have putaminal hemorrhage. So putaminal hemorrhage is actually the commonest form of intracerebral hemorrhage. Other sites of intracerebral hemorrhage also can be in the cerebral cortex. It can be in one of the loops of the cerebral hemisphere. For example, you can have intracerebral hemorrhage in the occipital loop or on the parietal loop. This is called lobar hemorrhage. Another important site is in the brainstem, specifically in the pons, pontine hemorrhage, also in the cerebellum, which is cerebellar hemorrhage. All these are forms and common sites for intracerebral hemorrhage, but the most common site of intracerebral hemorrhage is in the basal ganglia, affecting the lenticular striate arteries, which are derived from the middle cerebral artery, as we taught in the previous lecture. So what will be the clinical presentation in patients with intracerebral hemorrhage? As we mentioned in the previous lecture, stroke means an abrupt onset of neurologic deficit. You get a neurologic deficit of a sudden onset, and this neurologic deficit is referable and it's attributable to specific parts of the brain, and it's due to some vascular event. So it's a vascular in nature. It could be ischemic or it could be hemorrhagic. So in intracerebral hemorrhage, you will have a neurologic deficit similar to what happens in ischemic stroke. And the type of neurologic deficit will depend on the site of the hematoma, whether it's in the basal ganglia, whether it's in the cerebral hemisphere, in the loops, in which loop, whether it's in the cerebellum, and so on. But along with the neurologic deficit, you will also have features related to increase in the intracranial pressure, because when you have an expanding hematoma, this will increase the intracranial pressure, and then you'll start to have clinical features, symptoms, and signs related to increase in the intracranial pressure. For example, you will have severe headache, and also you can have blurring of vision, you can have visual impairment. You can also have vomiting, which can be projectile. You will have deterioration in the level of consciousness, altered consciousness. And on clinical examination, you can detect papilledema. You can detect also 6th cranial nerve palsy, this is the commonly affected cranial nerve when there is an increase in the intracranial pressure. So all these are features related to increase in intracranial pressure, and it can be seen with hemorrhagic strokes in general. And it will be in addition to focal neurologic deficits, which is related to the site of the hemorrhage. Also, due to if the hematoma is in the cerebral cortex, this can lead to irritation of the cerebral cortex, and this can lead to seizures as well. So these features, seizures, along with features of raised ICP, they are not usually seen in patients with ischemic stroke. And for that reason, this can clinically somehow differentiate hemorrhagic from ischemic stroke. But again, as I said previously, the only way to have an accurate differentiation between ischemic and hemorrhagic stroke is by brain imaging. Because sometimes large infarctions, like with middle cerebral artery, malignant syndrome, can present as hemorrhage. And sometimes small hemorrhage can present as an infarction without giving any raise in intracranial pressure. So the hemorrhage itself may expand or may be associated with the rim of cerebral edema. So the problem is not just related to the expansion of the hemorrhage within the brain parenchyma. This expanding hematoma is also associated with cerebral edema, and this will increase the intracranial further, will increase the intracranial pressure further. And this hemorrhage, along with the edema, will act like mass lesion, and it will lead to progression of neurologic deficit. And if it's big enough, it can shift the intracranial contents, leading to transtentorial coning and sometimes rapid death. So the main fear and the main concern with hemorrhagic stroke is that this significant increase in intracranial pressure with the hemorrhage and with the edema around the hemorrhage can eventually lead to brain herniation and can lead to respiratory cessation and rapid death. And as I said, along with that, the patient will also have focal neurologic deficits related to the site of the hematoma. And the most common site of the hematoma in intracerebral hemorrhage is in the basal ganglia, in the putamen. So you get putaminal hemorrhage. So what will be the clinical features here? As you know, in the basic knowledge related to anatomy, in the basal ganglia, the relations of the basal ganglia, medially to the putaminal part of the basal ganglia, you have the internal capsule. The internal capsule located deeply within the subcortical structures of the brain. And this internal capsule is actually walled by the basal ganglia and by the thalamus on the medial side. So when there is a hemorrhage affecting the putamen, the basal ganglia, this hemorrhage, this expanding hemorrhage, along with its surrounding edema, will compress and it will disrupt the internal capsule. So the features and the clinical features related to putaminal hemorrhage is actually related to affection of the internal capsule. You get features similar to what happens in capsular infarction, similar to what happens in patient with middle cerebral artery territory stroke. So you get contralateral dense hemiplegia. There is contralateral weakness, which is equal on both upper and lower limbs, associated with hemianesthesia. There is sensory loss on the contralateral half of the body. You get also an upper motor neuron facial palsy. You get contralateral homonymous hemianopia, which is a visual field defect because there is interruption of the optic radiation in the internal capsule. So basically, this hemorrhage in the basal ganglia will affect the structures and the tracts in the internal capsule. And this will give you focal neurologic deficits. And this can help you to localize the site of the hemorrhage. But another site for the hemorrhage also, as we said, is in the cerebral hemisphere. It's in the cerebral cortex. The hematoma can collect in one of the loops of the cerebral hemisphere. And more commonly tend to be in the parietal and occipital loops, more than the other loops. And according to the affected loop, you will have different types of neurologic deficits. For example, if the hematoma is in the frontal loop, because the motor area is in the frontal loop, the patient can present with contralateral weakness, or might present with Broca aphasia, because the Broca language center is in the frontal loop. Or, for example, if the hematoma is in the parietal loop, because the parietal loop is the sensory cortex, you will get some sensory deficits, contralateral sensory loss, or you might get astereognosis, or you might get hemineglect, as we talked previously, because these are all functions related to the parietal loop. If it's in the occipital loop, you will get visual field defect. If it's unilateral, you get homonymous hemianopia. In the temporal loop, you can get, for example, Wernicke's aphasia, because the Wernicke's language center is in the temporal loop. So according to the affected loop, you get different types of neurologic deficits. Then also, as we said, the hemorrhage can be in the brainstem, can be in the pons. And this can be considered as one of the worst types of strokes when you have a pontine hemorrhage, because this pontine hemorrhage will rapidly disrupt the reticular formation on the brainstem. And this can lead to deep coma. The patient can present with coma, can present with pinpoint pupils, constricted pupils. And this pinpoint pupils also seen with opioid overdose. So if you have deep coma, pinpoint pupil in association with stroke, this can indicate pontine hemorrhage, which is a form of intracerebral hemorrhage. Or if it's more anteriorly on the pons, it can lead to locked-in syndrome, as we discussed in the previous lecture. If you have cerebellar hematoma, there is a hemorrhage in the cerebellum. This cerebellar hematoma will present with occipital headache. There is always irritation of the meninges. Patient can present with neck stiffness, and there will be also cerebellar ataxia. But the problem with cerebellar hemorrhage, it can rapidly expand due to the narrow posterior cranial fossa, and it can compress anteriorly on the brainstem. And so it can compress vital centers, and it can lead to respiratory cessation and can lead to rapid death. So it's associated with poor prognosis. So according to the site of the hemorrhage, you get different types of different types of neurologic deficits. And along with these neurologic deficits, you get also features of raised intracranial pressure, and you can get seizures as well. This is about the intracerebral hemorrhage. So how to manage this type of stroke? How to manage hemorrhagic stroke, specifically intracerebral hemorrhage? In general, as I said previously, strokes ideally should be managed in acute stroke unit, or at least in ICU settings when we talk about intracerebral hemorrhage, with frequent monitoring of the DCS and neurologic signs. This is very important in order to monitor the progression of the hemorrhage. An initial point which can be done when you are dealing with any form of hemorrhagic stroke is to stop any anticoagulants or antiplatelets used by the patient. This should be stopped immediately. And along with that, you should try to reverse any clotting deficits if possible. If there is a coagulopathy, clotting deficits which can be corrected. For example, if this hemorrhage is related to warfarin overdose, then here you might do something. You can give PPC, you can give vitamin K, you can give fresh frozen plasma. So you will try to reverse the clotting deficits if possible. If there is severe thrombocytopenia, you might give platelet transfusion. And along with that, you should stop all the anticoagulants and antiplatelets. And they might be actually the cause or contributing factors for this hematoma. And you should monitor for seizures. This is very important. These patients are having very low threshold for seizures, and seizures will worsen the bleeding. It can increase the bleeding. And for that reason, you should always control seizures whenever you are dealing with hemorrhagic stroke. And even you can consider sometimes prophylactic anti-epileptic drugs, anticonvulsant drugs. And seizures especially are seen with lobar intracranial hemorrhage, when the hemorrhage is in the cerebral cortex, within the cerebral loops. You expect seizures to happen in these types of intracerebral hemorrhage. So you should have a low index of suspicion, and you should monitor for seizures. Then the important point in the management is the elevated blood pressure in patients with hemorrhagic stroke. Patients with hemorrhagic stroke, especially intracerebral hemorrhage, they tend to have very high blood pressure, because hypertension is actually the most common cause of intracerebral hemorrhage. And number two, because this high blood pressure is also part of the cerebral autoregulation, it's part of the compensation by the brain. Because, as I said previously, the cerebral perfusion pressure equals the mean arterial pressure minus the intracranial pressure. When you are dealing with intracranial hemorrhage, the intracranial pressure will increase significantly. And this increase in the intracranial pressure, according to the equation, it will lead to drop in the cerebral perfusion pressure. So the brain will try to compensate. The brain is already suffering from hemorrhage. So the brain will not want to add ischemia on top of hemorrhage. And for that reason, the blood pressure will increase, because increasing the mean arterial pressure will improve the cerebral perfusion pressure according to our equation. So whenever you have an increase in the intracranial pressure, you will always have an increase in the mean arterial pressure in order to improve the cerebral perfusion. So this will leave us with a dilemma regarding the management of hypertension, because high blood pressure will risk more bleeding. When the blood pressure increases further, bleeding will increase more. And low blood pressure, lowering the blood pressure, will lead to more ischemia, will lead to more hypoperfusion. So it's an equation. You want to keep the brain well perfused, and at the same time, you don't want to increase the size of the hematoma. As a general rule, according to the guidelines, it's recommended when you have a patient with intracerebral hemorrhage to lower the blood pressure to the systolic blood pressure to 140 millimeter mercury. It was shown that this level of systolic blood pressure is acceptable. It will reduce the risk of bleeding, of more bleeding, and at the same time, it will keep the brain with acceptable perfusion. So the target systolic blood pressure is 140 millimeter mercury. And you can achieve this target by using intravenous antihypertensive therapy. The most important and the most effective intravenous antihypertensive therapy here is labetalol. Labetalol is the most effective in lowering the blood pressure acutely in patients with intracerebral hemorrhage. And you want to lower the blood pressure to 140 millimeter mercury. This is a general rule according to the guidelines. An important point here, GTN should not be used. It's contraindicated when you are dealing with hemorrhagic stroke. This is an important point, because actually in our practice, the most widely available IV antihypertensive drug is GTN. And GTN is dangerous when you are dealing with intracranial hemorrhage, because it can drop the blood pressure significantly, and it's a vasodilator. It's not as labetalol. So GTN is not advised. It's contraindicated. It's not advised in patients with intracranial hemorrhage. If you want to lower the blood pressure with IV medication, use labetalol. Then what is the rule of surgery? When you have hemorrhagic stroke, we think about surgery, but what is the rule of surgery in intracerebral hemorrhage? In intracerebral hemorrhage, actually, despite that it's a hemorrhagic stroke, but the rule of surgery is limited, and it's limited to cerebellar hematomas. So surgery with the evacuation, craniotomy and evacuation of the hematoma can be considered in cerebellar hematomas, because this can be considered as easily accessible from the posterior cranial fossa compared to other forms of hematoma. If you have putaminal hemorrhage, which is the most common type, it's not accessible for surgery. So surgical evacuation of the hematoma is considered if you are dealing with cerebellar hematomas. And also surgery can be considered in form of ventriculoperitoneal shunting if there is an element of obstructive hydrocephalus, and this is one of the complications associated with hemorrhagic stroke. If there is obstructive hydrocephalus, then you can do VP shunt as part of surgical management, and this to lower the blood to intracranial pressure. So the second type of hemorrhagic stroke is subarachnoid hemorrhage, and this is a form of hemorrhagic stroke a form of bleeding into the subarachnoid space. And the etiologies of subarachnoid hemorrhage can be traumatic or non-traumatic. It can be spontaneous or it can be traumatic. The most common cause of spontaneous, non-traumatic subarachnoid hemorrhage is rupture of perianeurysms. This is the most common cause of spontaneous subarachnoid hemorrhage, non-traumatic. And these perianeurysms are usually found within the anterior circulation, and the most common artery associated with perianeurysm is the anterior communicating artery. But it can be seen in other parts of circumflex, for example, in the posterior communicating artery. And this rupture of the perianeurysms can be associated with different conditions associated with collagen disorders, like polycystic kidney disease, like Ehlers-Danlos syndrome, for example. In this condition, there is weakening of the blood vessels, and this can lead to aneurysmal dilatation, which can affect the brain tissues. And the rupture of the aneurysm might be triggered by hypertension. If there is a sudden rise in the blood pressure, sudden surge and sudden rise in the blood pressure due to sympathetic overflow, this can trigger the rupture of the pre-existing aneurysm. And for that reason, patients with subarachnoid hemorrhage, in a lot of cases, they present with severe headache, they present with the subarachnoid hemorrhage after a situation which significantly and suddenly increased the blood pressure. There is an increased sympathetic stimulation, which has led to sudden rise in the blood pressure, and this has led to rupture of the perianeurysm. Then also other causes of spontaneous subarachnoid hemorrhage include AVMs, and it might be also due to coagulopathies, patient on warfarin, for example, due to brain tumors. Also, subarachnoid hemorrhage can be due to arterial dissection, for example. Arterial dissection also, which is associated with ischemic stroke, can also lead to subarachnoid hemorrhage. And the arterial dissection starts usually from the extracranial vessels. It will not start in the intercranial vessels. It starts in the extracranial vessels, either in the carotid system or in the vertebral system. But bleeding in the extracranial vessels will not occur because the adventitial lining of the extracranial vessels is tough and thick compared to the adventitial lining of the intercranial vessels. And for that reason, although the dissection starts extracranially, but the rupture and bleeding from the artery will not happen in the neck. It can happen intercranially because the adventitial lining in the extracranial vessels is stronger and tougher. And for that reason, it will not lead to extracranial bleeding. So these are examples of causes of subarachnoid hemorrhage. So what will be the clinical features? The clinical features in subarachnoid hemorrhage is a little bit different than other types of strokes. As we said, strokes usually characterized by focal neurologic deficit. But in subarachnoid hemorrhage, in a lot of cases, you might not detect any focal neurologic deficit. The features are more generalized. And the commonest feature is severe headache. You get a sudden onset excruciating headache, which is described as thunderclap headache. When you talk about thunderclap headaches, this means severe and sudden onset headaches. One of the differential diagnoses of thunderclap headache is subarachnoid hemorrhage, but it can be seen with other conditions, for example, like pituitary apoplexy, like cortical vein thrombosis. Anyway, subarachnoid hemorrhage gives you severe headache, which is described usually by the patient as the worst headache ever. And this is the main feature seen in subarachnoid hemorrhage. And the patient usually, before developing this headache, the patient would have some sort of situation which is associated with sympathetic overflow. And this sympathetic overflow is the trigger of the high blood pressure, which will trigger the rupture of the perianeurysm. So the patient might be exerting. There might be some sort of exertion before the onset of the headache. And along with this headache, the patient also can have features, again, related to increased intracranial pressure, as we discussed previously. There might be altered consciousness. The patient might develop vomiting. There might be visual impairment, and the patient can also develop seizures, the same features as seen in intracerebral hemorrhage. And along with that, the bleeding here is in the subarachnoid space, and this will lead to irritation of the meninges. So you will have features of meningism, feature of meningeal irritation, resembling meningitis. And this include neck stiffness, Kerning sign, photophobia. And what makes things difficult, sometimes even subarachnoid hemorrhage can give you mild fever, can give you low-grade fever. And this might mimic meningitis. So meningitis can be important differential diagnosis here. And after that, also in some patients, because it's a stroke, so you can have focal neurologic deficits. These focal neurologic deficits can be due to two main situations. It could be either due to the site of the aneurysm. Maybe the aneurysmal dilatation is adjacent to important structure, and this has led to neurologic deficit. And the common scenario here is in posterior communicating artery aneurysm. When you have a posterior communicating artery aneurysm, the oculomotor nerve, the third cranial nerve, is in close proximity, in close relation to the posterior communicating artery. So whenever there is posterior communicating artery aneurysm, this can compress the oculomotor nerve, and the patient will have focal neurologic deficit in form of third cranial nerve palsy. And regarding the third cranial nerve palsy, the important point here in the fibers that the third cranial nerve palsy, that third cranial nerve is distributed in a special way. Yani, third cranial nerve, sympathetic fibers are located outward, while motor fibers are located inward. So when you have a posterior communicating artery aneurysm, this can press on the oculomotor nerve palsy. You have features related to the oculomotor nerve, like mydriasis. There might be dilated pupil, there might be ptosis, dropping of the eyelids, and there might be diplopia. And this is one of the focal neurologic deficit. But another situation in which also subarachnoid hemorrhage can lead to focal neurologic deficit is when this condition leads to cerebral vasospasm. The blood which is present in the subarachnoid space can irritate the blood vessels, and this can lead to cerebral vasospasm. It can lead to vasospasm of the cerebral blood vessels. And this cerebral vasospasm will lead to ischemia to the brain. So subarachnoid hemorrhage can add ischemic injury to the brain due to cerebral vasospasm. And this cerebral vasospasm with subsequent brain ischemia can also precipitate focal neurologic deficit. If there is spasm along the middle cerebral artery territory, you will get focal neurologic deficit related to middle cerebral artery, area supplied by the middle cerebral artery. And these are focal neurologic deficit, which can be seen as a complication of subarachnoid hemorrhage. But remember, in most of the cases, subarachnoid hemorrhage present with severe headache with features of increased intracranial pressure without focal neurologic deficit, and with meningeal irritation signs. So an important point when you talk about subarachnoid hemorrhage, how to diagnose it. The diagnosis of subarachnoid hemorrhage initially should start with urgent brain CT. Whenever you are suspecting subarachnoid hemorrhage, and actually in any form of stroke, we start with urgent brain CT, with non-contrast brain CT. The non-contrast brain CT actually can diagnose more than 95% of cases of subarachnoid hemorrhage. And for that reason, it's the initial test, and it's a rapid test. In those little number of patients, little percentage of patients which are not diagnosed on brain CT, if brain CT failed to diagnose subarachnoid hemorrhage, the next step is to do lumbar puncture. To do lumbar puncture to look for xanthochromia. Xanthochromia is the yellowish discoloration of the CSF, and it's due to hemolysis which happens within the CSF. When you have subarachnoid hemorrhage, you will have hemolysis in the CSF, and this hemolysis within the CSF will lead to release of bilirubin, and this bilirubin will turn the CSF color into yellow, and this is called xanthochromia, and it can be detected on CSF examination. But in order for this xanthochromia to be detected, you need 12 hours post the onset of subarachnoid hemorrhage. So for that reason, it takes time for the RBCs to undergo lysis and to lead to xanthochromia. So if the brain CT failed to detect subarachnoid hemorrhage, the next step is to do lumbar puncture after 12 hours from the onset of subarachnoid hemorrhage to look for xanthochromia. And finally, we can do CT angiography of the brain. This CT angiography of the brain can be considered as the accurate way to diagnose subarachnoid hemorrhage. It can be used if the other modalities failed to diagnose subarachnoid hemorrhage, and also it should be used in any patients anyway to evaluate the anatomy of the cerebral circulation and to locate the site of the rupture, and to look if there is any other silent aneurysms which have not ruptured yet, which will require also to be addressed. So CTA should be done anyway in any patient with subarachnoid hemorrhage. So this is basically how to diagnose subarachnoid hemorrhage. Then also on ECG, there are certain features which can be seen with subarachnoid hemorrhage. It might have symmetrical, deeply inverted T waves. You can have also ST elevation in some patients. you can have prolongation of the QT interval. These are non-specific findings on ECG seen with subarachnoid hemorrhage. Finally, let's talk about the treatment of subarachnoid hemorrhage. When you talk about spontaneous subarachnoid hemorrhage, the treatment will be according to the causative pathology, whether it's perianeurysm or it's AVM. Regarding aneurysms, which are the most common cause, the main problem related to aneurysm, it's associated with high risk of rebleeding. This is the main complication associated with subarachnoid hemorrhage, especially due to aneurysms. There is high risk of rebleeding. And for that reason, the intervention should be rapid when you are dealing with subarachnoid hemorrhage. You should consider neurosurgical intervention urgently whenever you confirm the diagnosis of subarachnoid hemorrhage, preferably within 24 hours. You should not delay neurosurgical consultation. This is different than intracerebral hemorrhage. Intracerebral hemorrhage, the rule of surgery is weak and it's limited. But here, the main management is surgical in subarachnoid hemorrhage, and it should be done as soon as possible to prevent rebleeding, which can be serious. The type of surgical intervention can be either with endovascular coiling by a neuroradiologist, or it can be by surgical clipping. And here it's performed by a neurosurgeon. We're not going into details of these surgical procedures, but these are the two procedures which can be considered if you are dealing with subarachnoid hemorrhage due to ruptured perianeurysms. Either neuroradiological coiling by a neuroradiologist or surgical clipping by a neurosurgeon. But until, if you are dealing with AVM, if the lesion was found to be AVM, in AVM, we do endovascular embolization. This is the strategy which is done in subarachnoid hemorrhage due to AVMs. But until the aneurysm is treated, the patient should be kept on strict bed rest, well-controlled blood pressure, and should avoid straining in order to prevent rebleeding. This is the main strategy. This is the main aim of our medical treatment. Beside the surgical treatment, our medical treatment is mainly focusing on preventing rebleeding. You should prevent and should control anything which risks rebleeding. For example, the patient should be kept immobile, should be on strict bed rest. If there is any form of strain, should be controlled. For example, if there is constipation, if there is urine retention, all of these should be controlled. The pain itself, the severe headache of the patient, the pain itself is associated with risk of rebleeding because it will increase the sympathetic stimulation. And this will lead to more increase in the blood pressure, and this will lead to more risk of rebleeding. So you need to control the pain. You can give tramadol to control the pain. And also, seizures should be addressed. If there is any seizures, should be controlled, and you should monitor for seizures. And even you can consider prophylactic anticonvulsant therapy. So all these measures are considered to prevent rebleeding, which is a major complication associated with subarachnoid hemorrhage. Then also we can use a drug which is called nimodipine. Nimodipine is a selective calcium channel blocker. It's a calcium channel blocker which selectively acts on the cerebral blood vessels. It dilates the cerebral blood vessels, and hence it's used to prevent cerebral spasm. It's beneficial in prevention of cerebral vasospasm. It will not be used to treat cerebral vasospasm once it has developed. It will not help once the cerebral vasospasm and ischemia has developed. It's used to prevent the development of cerebral vasospasm because it will dilate the cerebral blood vessels. And this is part of the medical treatment in subarachnoid hemorrhage. So subarachnoid hemorrhage, once you diagnose patient with subarachnoid hemorrhage, the initial step, you should acquire urgent neurosurgical consultation because the main management is neurosurgical, either with endovascular coiling or surgical clipping or embolization in case of AVM. Before that, you need to do an angiography in order to determine the site of the pathology and the nature of the pathology and if there are multiple vessels affected. And meanwhile, until you do the accurate and the definitive treatment, you need to medically control the patient, control rebleeding to prevent anything which can risk rebleeding and to prevent cerebral vasospasm with nimodipine. The main complications associated with subarachnoid hemorrhage, besides rebleeding, also it includes seizures, can lead to seizures, which will worsen the bleeding. Also, another complication is obstructive hydrocephalus, and along with that, cerebral vasospasm, as we said. And some patients also might develop hyponatremia due to syndrome of inappropriate ADH secretion. All these are possible complications associated with subarachnoid hemorrhage. This is brain CT showing features of subarachnoid hemorrhage. As you can see, there is blood within the subarachnoid space. There is blood affecting the basal cisterns, and it's affecting also the interhemispheric fissures, and on the lateral sulcus, on the Sylvian sulcus as well. All these are classical features of subarachnoid hemorrhage, and as I said, in more than 95% of cases, subarachnoid hemorrhage can be diagnosed on brain CT. This is an intracerebral hemorrhage, as you can see. It's bleeding into the brain parenchyma. And specifically here, the bleeding is in the area of the basal ganglia, and it's affecting the internal capsule. So this can be considered as an intracerebral hemorrhage. And this is the most common type of intracerebral hemorrhage in the area of the basal ganglia. Another picture also showing intracerebral hemorrhage. This can be considered as lobar intracerebral hemorrhage. And here, this is intracerebral hemorrhage with intraventricular spilling. There is an intraventricular extension. The hemorrhage has spilled into the interventricular cavities, to the interventricular cavities. So here we finish our session. Any questions?
I would like to ask about lumbar puncture, Dr. Khalid. Is it mandatory to do it, or if I just have like normal CT?
Yes,
so I
exactly.
need to move to lumbar puncture.
Yes, you should not do lumbar puncture unless brain CT failed to show subarachnoid hemorrhage, and you're still considering a diagnosis of subarachnoid hemorrhage. Then the next step, you do lumbar puncture. But you have to make sure there is no contraindication for lumbar puncture. You should do fundoscopy examination to exclude papilledema and so on. But not every patient should undergo lumbar puncture in subarachnoid hemorrhage. Only those with CT negative subarachnoid hemorrhage.
So if I suspect it, I need to wait for 12 hours after CT,
yes.
then wait.
Yes, this is the ideal stepwise approach in subarachnoid hemorrhage.
But I think Dr. Khalid في آخر guidelines إنه if a CT done within 1 hour from the presentation, and it's like reported from expert radiologist that there is no intracerebral hemorrhage, so no need to go for LB unless you are suspecting something else.
Yeah, it will not go to LP in any patients. It depends on your clinical judgment. Always depends on your clinical judgment, because you might consider other possible differential diagnoses at the same time. It's not always subarachnoid hemorrhage if the presentation is with severe headache and so on. You have parallel thinking. You should also try to exclude other possible differential diagnoses, especially, for example, if you have a female patient's history of contraceptive pills and so on. There are possible differential diagnoses. But if you are still having clinical suspicion of subarachnoid hemorrhage despite CT negative, you can proceed to lumbar puncture. Any more questions regarding the whole lecture? In previous session, not just this session.
السلام عليكم.
وعليكم السلام ورحمة.
وانت بخير دكتور خالد.
وانت بخير يا دكتور.
الله يحفظك. الله يحفظك. دكتور خالد regarding الستروك الاسبرين 300 ملغ. انت قلت احيانا بنبدا ممكن ناخذ اسبرين وكلوبيدوغريل مع بعض. ممكن نبدا بهم. اول مره قلت بناخذ 300 ملغ for approximately 2 weeks. After that we will continue on 75 ملغ اسبرين قصدك و75 ملغ كلوبيدوغريل صح؟
ده اذا بدينا بهم initially dual therapy. ما هي different guidelines.
ناخذ 300 ملغ اسبرين for 2 weeks.
ايوه. But a nice guidelines, they are advising aspirin for 2 weeks with high dose, 300 mg. After that, clopidogrel as a secondary prevention.
75 only milligram, 75 milligram clopidogrel only.
Clopidogrel only, for secondary prevention after 2 weeks.
if we considered only aspirin, we will continue for 300 milligram for how long? If we considered only aspirin due to concerning about bleeding, about hemorrhage, about any
aspirin, who according to the studies, as I said, it showed to be beneficial في acute settings of stroke. يعني in preventing recurrence of stroke, especially في the first 2 weeks. يعني giving aspirin will significantly reduce the recurrence في the early period after stroke, and it will reduce the mortality في the acute setting of stroke. عشان كده احنا بنستخدم الاسبرين acutely with high dose for 2 weeks. لكن for secondary prevention, the long-term secondary prevention is with clopidogrel monotherapy. لكن في specific trials اتعملت لقوا انه specifically in those people who are having TIA with ABCD score 4 or more, or patients with minor stroke according to the NIH stroke scale, those patients can be treated initially with aspirin in combination with clopidogrel for 21 days. This is different يعني strategy. For 21 days aspirin and clopidogrel. After that it will be followed by clopidogrel. Like always, a secondary prevention, a long-term treatment is with clopidogrel alone. This is the fixed rule.
Thank you very much, Doctor.
You're welcome. I hope it's clear. Is there any more questions?
MashaAllah, it was very clear, Dr. Khalid, and you cover everything. Yani, special thanks and appreciation yani, for your time, wallahi.
You're welcome. I hope everything is clear. I hope I was able يعني, to provide you يعني, with some يعني, information. ممكن تكون ما كان available شوية كده. بعض الأحيان الجايدلاينز الكلام بيكون كتير ويعني متضارب وكده. I try to simplify يعني recent guidelines. وطبعا في different schools, as I said, with different strategies in the management. It's difficult to catch everything يعني. For those who are يعني, willing to take MRCP exams, always we follow a nice guidelines for MRCP exams. لكن also يعني, sometimes even nice guidelines, they recommend to follow other guidelines. They recommend you to follow the American Heart Association or American Stroke Association or any other American guidelines. The American guidelines يعني, are very thorough يعني, in their guidelines. When I think يعني, their guidelines tend to be يعني, more simplified compared to the British guidelines. So there are different schools when you talk about stroke, and when you talk about other يعني, conditions in medicine. Try to keep to be open-minded and to look here and there, and not just to be يعني, fixed في specific guidelines, nice guidelines, or any specific guidelines, and so on. لأنه في different schools.
المشكلة we are going to take an MRCP, so that's why we think about that.
Yes, of course. As I said, for MRCP you need to follow. You need to follow mainly the nice guidelines, but sometimes there are certain areas يعني nice guidelines نفسها ما بتكون يعني addressing it. You need to look elsewhere يعني when you talk about it. And surprisingly, even in the exams يعني في questions they appear بتكون following other guidelines, not just nice guidelines. طيب في سؤال ثاني قبل ما finish our session.
شكرا جزيلا.
عفوا، وان شاء الله نلتقي مره ثانيه ان شاء الله في another session نشوف لنا another topic ممكن يعني في next weeks. We will try to do another session ان شاء الله.
طماعين، ما دارين نكون طماعين يعني تور بريجر طبعا.
لا طوالي في الخدمه ان شاء الله، ووقت ما ان شاء الله لقينا وقت كده كويس we will do ان شاء الله another session maybe in neurology or maybe in other يعني chapter. I hope يعني برضو تكون يعني beneficial ان شاء الله. If anyone has any question يعني you can address question يعني in private messages. My number and Dr. Rasha. I think يعني anyone has anything any question regarding the lectures, feel free anytime.
يا سلام، بارك الله فيك، وإن شاء الله ربنا يزيدك علم يعني. بارك الله فيك.
عفوا، شكرا لك، كل سنة وأنتم طيبين، وشكرا لكم مرة ثانية اديتوني فرصة أتكلم معاكم.
لا والله إحنا شاكرين لوقتك يعني. It was an amazing session يعني جد.
عفوا.
شكرا جزيلا، بارك الله فيك.
شكرا لكم، انت تسلم.
جزاك الله خير.
السلام عليكم.
جزاك الله.
الله يعافيك ان شاء الله. شكرا لكم.
شكرا جزيلا.